Here's our roadmap for today. We're going to hit classification, move into management, grab a key clinical pearl, look at a classic exam trap, and finish up with a quick recall question.
All right, Section 1, Classification, the Rockall score. So let's get our definition straight right off the bat. The Rockall score is this absolutely essential scoring system used for one specific, highly dangerous clinical scenario, an upper gastrointestinal hemorrhage. You know, when a patient comes in vomiting blood or passing melena, those dark, tarry stools, our biggest concerns are basically twofold. One, are they going to bleed again? And two, what's the risk of dying? The Rockall score predicts exactly those two things, the risk of rebleeding and the risk of mortality. And it does this by mashing up what we see clinically right at the bedside with what we actually find when we look inside with a camera.
Now, how's the whole thing structured? Well, the total score ranges from 0 to 11. A 0 is your best case scenario, and 11, yeah, that's the absolute worst. But the really crucial point here is that this score is split into two very distinct phases. First, you've got the pre-endoscopy component, which relies purely on clinical signs. Then, you've got the endoscopic component, which relies entirely on the physical findings from the camera. Let's break down that first part.
Okay, check this out. Notice how risk is assigned before we ever do a procedure. This is your clinical Rockall score. We are looking at three main things here: age, shock, and comorbidity. For age, being under 60 gets you a nice 0 points, but if you're 80 or older, you instantly get 2 points. Then we look at shock. If a patient is stable, systolic BP over 100, pulse under 100, that's 0. But if that systolic blood pressure drops below 100, that is a massive red flag for blood volume loss, granting them 2 points right away. But look down at the bottom row. Comorbidities are huge here. If your patient has renal failure, liver failure, or a disseminated malignancy, boom, 3 points. That's actually the biggest single jump in the clinical criteria. It immediately spikes their risk profile before the endoscope even enters the room.
So, once the patient is stabilized and gets an endoscopy, we move to the second half of the score. The endoscopic component looks at diagnosis and stigmata of recent hemorrhage. If the scope shows a simple Mallory-Weiss tear from vomiting, or maybe no obvious lesion at all, that's 0 points. But if you spot an upper GI malignancy, that adds 2. Then we look for the stigmata, basically the signs of recent bleeding. If the area is clean or just has a dark spot, 0 points. But if you see active blood in there, an adherent clot, or a visible vessel, you gotta add 2 points. Actually, a visible vessel means a major pipeline has been breached, making rebleeding incredibly likely.
Moving on to Section 2, Management by Risk Level.
If you crunch the numbers and the Rockall score is low, that suggests a low risk of mortality and a low risk of rebleeding. You're in the green zone. For these low-risk folks, you definitely don't need to keep them occupying a hospital bed indefinitely. The management pathway here allows for early discharge in selected patients. We can just set up outpatient follow-up, start them on some solid acid suppression therapy, like a PPI, and focus on treating the underlying cause safely out in the community.
But what if the score pushes them into the intermediate or high-risk category? We're in the yellow zone now, and this fundamentally changes the game. These patients require formal admission. You need to actively resuscitate them and get an urgent upper GI endoscopy ordered. And while they're in there, if the gastroenterologist or surgeon sees active bleeding or high-risk signs, they're going to do endoscopic hemostasis, meaning they will physically intervene to stop the bleed. Once that high-risk ulcer or lesion is treated endoscopically, the pathway says to step up to high-dose PPI therapy to help that area heal and prevent it from happening again.
And then we hit the red zone, the very high-risk patient. This is an all-hands-on-deck situation. These patients absolutely require intensive monitoring, usually in an ICU or a high-dependency setting. They need endoscopic hemostasis right away. If they rebleed, you go right back in for a repeat endoscopy. And this is a brilliant illustration of the surgical escalation pathway, because if endoscopic control fails, you don't just keep messing around with the camera. The management clearly states you must escalate, either to interventional radiology to embolize the bleeding vessel, or take the patient straight to the operating theater for emergency surgery.
All right, Section 3, Key Clinical Pearl. So a really great way to lock this into your memory for exam day is to just focus on these 5 core pillars. The Rockall score evaluates exactly 5 core elements. That's it, just 5. Age, shock, comorbidity, diagnosis, and endoscopic bleeding stigmata. If you memorize these 5 categories, you can intuitively reconstruct the entire scoring system in your head during a high-pressure exam or on a really busy ward round.
And a huge part of that clinical pearl is just understanding the timeline. It's totally vital.
The clinical Rockall score, the age, shock, and comorbidities, can and absolutely should be calculated before the endoscopy. But the full Rockall score, that requires a camera going down to actually see the diagnosis in bleeding stigmata. You literally can't get the full score without those endoscopic findings. Keep that sequence straight in your head for sure.
Next up, Section 4, the classic exam trap.
Okay, pay close attention, because this is literally the #1 trap in upper GI bleeding questions. Examiners love confusing the Rockall score with the Glasgow-Blatchford score. Guys, they are not the same thing, and they're used at completely different times. Let's put them head-to-head. The Rockall score, as we've learned, includes endoscopic findings, right? It predicts mortality and the risk of rebleeding after a bleed has occurred and been visualized. On the other hand, the Glasgow-Blatchford score is based entirely on clinical and laboratory parameters, stuff like urea and hemoglobin. There is zero endoscopy involved in a Glasgow-Blatchford score. Because it only uses pre-endoscopic data, its whole job is to help identify the need for an intervention. Basically, Glasgow-Blatchford tells you if they need the camera, Rockall tells you their outcome based on what the camera actually found. Do not mix these up.
There's also a secondary kind of subtle trap I want to point out. A high Rockall score equals a high risk. It means the patient has a high risk of dying or bleeding again. It does not equal a specific diagnosis. A score of 10 doesn't automatically mean it's a bleeding ulcer, and it doesn't automatically mean it's a malignancy. It just means whatever is bleeding down there, combined with the patient's physical state, is highly, highly dangerous. It measures severity, not the pathology itself.
Finally, Section 5, quick recall question.
Let's see how much you retained. Consider this scenario carefully. An elderly patient comes in with upper GI bleeding. They have hypotension. They have a known history of renal failure. They undergo an endoscopy, and the doctor notes a visible vessel. Take a second. Think about what categories we are hitting here and what that means for our patient's management.
Got your answer? If you said this indicates a very high Rockall score, you hit the nail on the head. Let's break it down really quick. Elderly gets points for age, hypotension grabs points for shock, renal failure gets the maximum points for comorbidity, and a visible vessel, maximum points for endoscopic stigmata. This patient is racking up points in almost every single category, which indicates a massive risk of mortality and rebleeding. Clinically, this means they require immediate admission, intensive monitoring, and highly active management, likely including endoscopic hemostasis or surgery. Well, you've just successfully navigated one of the absolute most important scoring systems in acute surgery. But it leaves us with kind of a wild clinical dilemma, doesn't it? If a patient scores a 0 on a validated tool like this, guaranteeing statistical safety, but your own clinical intuition tells you something is terribly wrong, which do you trust, the math or the doctor? Thanks for joining this explainer, and we'll catch you next time.